So we're going to start off. Rural communities, we have a lot of unique challenges. Workforce shortages, rumors of hospital closures, behavioral health services, lack thereof. So from your perspective, tell us from your organizations, what are your biggest challenges and what are you all doing to address them? Anybody can jump in.
Well, I'll start us off.
Okay.
You know, I think Kaylee really did a great job kind of outlining the state of healthcare and a lot of the same challenges that we have in rural healthcare. We have in urban areas or small urban areas, but certainly rural health has its uniqueness. I think the biggest challenges that we face is just the long-term financial viability. What we really like to do is to talk about what services our community needs, right? How we can enhance those, bring in different specialties, physicians. How do we deal with workforce from a clinical standpoint, certainly from a physician standpoint, but all of those ideas and services take financial sustainability, you know, and so we spend a good bit of time talking about that, and Kaylee laid that out, and the challenges that we have at the national level and at the state level, but she also laid out some solutions for our rural communities. The Georgia Heart program, where you can redirect dollar for dollar your tax burden to a rural hospital here in the state. And if you live in a county that you're not a rural county, you can still direct your dollars. We get many dollars that come out of the Atlanta area. Those have been sustaining for many rural hospitals in Georgia. Has been a great program, a great partnership with the state. You know, so I think it's programs like that. You're going to hear from Commissioner Burke. The innovation that comes out of DCH, it's an open line of communication that we have with them and have had with the department, and because they're just as concerned. So I think we truly have partners in the state. The governor's concerned, you know, we can solve a lot of those challenges on our own as well. We just need to be innovative, and then we have to be involved.
Absolutely. I would say from a behavioral health perspective, there's a very long answer to the challenges that we have. So I brought my notes, and we've got page 1 right here. But 150.5, because one county is split in half, of 159 counties in Georgia is considered underserved from a behavioral health, mental health perspective. And I break it into 2 camps of underserved. One would be individuals looking for outpatient treatment, depression, anxiety, stressors. They're not at a crisis point, but they really need help. And then you've got your inpatient level of care when individuals are going into crisis. I would say I believe Georgia is progressive with the support of DCH and DBHDD in that they have grown quite a few resources for individuals that go into crisis. There are also quite a few other programs out there for individuals who go into crisis. I would say for that level, there are sufficient what we call beds in Georgia, but they are not located mostly in rural areas where if you have a loved one go into crisis, you can see them, be close to them. The other issue is while they may be there, access is an issue. It is, many people don't know how to get access, and they often just result to going to emergency rooms, which then can clog up the emergency rooms and keep people from having the emergency room beds they need to treat their medical conditions. So again, there are solutions for that, but I think right now that in that area, that's what the challenge is. For outpatient treatment, a lot of it comes to what Kaylee and Scott talked about too, is recruiting the professionals to rural areas, which has many facets. One, do we have childcare in those areas? Can we employ their spouses? I was looking at some data that said in rural areas, only 20% of physicians practice there. And then in Georgia, that's down to 10%. So there's just a shortage overall for those providers? And then is there enough volume for them to stay afloat? And then reimbursement. Are they able to make ends meet? And so that's often, that formula doesn't work out, and so you don't have the providers in our rural areas.
That's right. Commissioner Burke?
Well, thank you. I want to apologize to the mayor of the city of Fitzgerald, because
Same.
they make him look a lot uglier than he probably is. Appreciate the invitation to be here. It's always great to have an excuse to have city of Atlanta in your rearview mirror. Coming south today, I was telling my folks at my table that it's the first time I can remember going through Henry County that I didn't have to tap the brake light. So, I mean, today's just a blessed day. So,
It's a good day.
But just a little background about me, because you're probably wondering, you know, what the hell does he know about healthcare? I was born in Donaldsonville, which is, for those of you that don't know, is deep southwest Georgia. I tell people to you know, go to Florida and then do a U-turn, and you'll be in my community. My passion in grade school and high school was becoming a physician, and other than one semester in undergrad, Dr. Carbajal, did I go pre-law, and I was sitting in the classroom and I was thinking, what in the hell am I doing in here? So anyway, I went back to pre-med and went to Medical College of Georgia on a country doctor scholarship, which is, they don't call it that anymore, but there's still an arrangement, and went back to Southwest Georgia to practice OB. So I practiced obstetrics and gynecology in a small town for almost 30 years. During that time, I was also active in the community, the chamber, Rotary Club, and got talked into roles such as being on the Planning and Zoning Board, which is was a really good preparation for what I did later on in my life, because that's one of those things where you're making somebody mad every day. And then became a city councilman, never made the mayor, and then ran for the state senate. And during my senate term, I served there for 10 years. 8 of those years, I was the appropriations chair for the healthcare budget. So I learned a lot about healthcare finance during that time. And at the same time, I was the chief medical officer for a small rural hospital in Bainbridge, Memorial Hospital in Manor. And in a rural facility like that, you wear a lot of hats. So we were all immersed into the healthcare finance world that were on that leadership team. So I've kind of lived and bled through all the challenges that people are talking about today in rural healthcare. Our facility went through reductions in force at least twice or 3 times during my career there. Many times where we were trying to figure out which vendor to pay and so that we could continue to make payroll. So all those things, I'm just explaining that this is a deeply personal issue for me. My role now is the commissioner at the Department of Community Health. For those of you that don't know, the Department of Community Health manages the Medicaid program. That's our biggest budget item. We cover over 2 million Georgians in Medicaid. And State Health Benefit Program, which is the health care benefit for state employees and retirees. We have almost 800,000 lives. So we're probably one of the biggest insurers on the East Coast as far as the number of lives that we touch in our programs at DCH. And, you know, on the side, we also license and manage the nursing homes and hospitals and all the other healthcare facilities to regulate them, certificate of need program. So there's a lot going on in our agency. But the Rural Transformation Fund that was just been brought up, I'm going to go ahead and jump ahead. I'm sorry,
Okay.
since I've got the mic. I'm a politician. I just can't help it, even though I'm retired. you know, it's a unique situation, and we're doing the work that Kaylee's already mentioned most of the details, so I really won't get into that. But I want people to understand that we went out very early, as soon as this was announced by Congress and the President, that part of that HR bill was going to go to rural health care. We had town halls across the state. We had a portal open on our website to get ideas, and we, you know, made sure all of the folks that are stakeholders in this business knew that this was coming, and we wanted to harvest the best and the brightest ideas that we could in order that we could make a really aggressive pitch to the federal government that we deserve our share and maybe even a little more than our share. Georgia does have a lot of unique challenges as far as our healthcare outcomes. You know, I always love coming back to Southwest Georgia, but I also kind of feel guilty in that we still, you know, love our fried chicken and our peach cobbler. And from a healthcare outcomes, you know, maybe that's not the best thing to do. So I was trying to be a good steward and got the baked chicken today. So just so y'all know. And I skipped the peach cobbler, which was hard. But the amount of money that they're talking about going to rural Georgia is unprecedented. And I truly, the way I put it is a little simpler than Kaylee, because she's the math nerd and I'm just a poor country doctor. But the healthcare business model in rural Georgia is broken. You know, it doesn't work. If you tried to go to a bank with that business plan of, oh, here's our cost and here's our revenue, they would laugh you out of the door. And so we've got to use this money to transform delivery models in a way that allows facilities to have a margin and stay open. And that's just the bottom line. And so we had lots of requests, and we'll certainly do our best to do what I call one-off things, where somebody needs an ambulance or somebody needs, as we mentioned, a roof or a generator. I mean, those kind of things are certainly important. But we're planning on trying to figure out with the federal government's help, because we can't do any of this without approval from CMS, but to change the payment model to more of a value-based and outcome results-driven, because the current fee-for-service is just a loser for us because of the way the structure is. And that's very complicated, and it scares providers because it's new, it's different, and it requires a lot of technology that they may not have now, hospitals or frontline providers. And keep in mind, when I'm talking about healthcare, it's not just hospitals. Behavioral health, obviously, is a huge, huge piece of healthcare delivery system. And if you don't have the behavioral health services, it doesn't matter how good of a acute care you give, people are not going to get better. And so that's just a quick summary of what's on our plate, and that deadline for that application is in a couple of weeks, and we're working night and day to try to get it to the point where we can hopefully get, as I said, way more than our share if you just look at it on the math. But
that's great. We all know in small towns we depend on one another, and so partnerships and collaborations are key to our success. Can you share some examples where working with physicians, providers, hospitals, government entities, business leaders have made a real difference, and how then, we always say at the center, we need to make it sustainable and replicable, because that's where the real success lies. So can you give us some instances where you've seen that work and you've had those models?
Sure, I'll start.
Okay, great.
So, yeah, you know, our healthcare, we have many partners in our healthcare system. You know, I never thought, if you had asked me probably 6 or 7 years ago, would you be as involved in the development of workforce that you are today, and investing the dollars, and we've invested more than $100 million in the last 5 years. That's not our job, right? Our job is to help people who are sick or injured or, not to grow the workforce, right? That's the job of our universities and colleges and schools and, others. COVID changed a whole lot, and that was just one of them. And so we are immersed in being a partner with, if somebody says that they can train, I was just talking to folks from Southern Regional Tech who have an MRI training opportunity, and we're asking, do we need MRI technologists? And the answer was yes, we are desperate for it. CT, X-ray, ultrasound, nuclear medicine, telemetry, you name it, accountants. We have a need right now in our health system. At Phoebe, we have more than 500 openings, and 200 of them are nurses. And certainly we can talk about doctors, and we're talking about relationships with medical schools and making significant investments. And so we see it as just that, an investment and a partnership of how do we create the workforce of the future. Certainly we're selfish, but we know that less than 10% of all doctors that come out of training are really thinking about rural medicine. And that has got to change. That has got to change, because if it doesn't, right, we're not going to have the providers. I'd imagine folks in this room have had the opportunity to call and get an appointment, and it's taken, they say, well, how about 4 weeks or 6 weeks or 8 weeks or 6 months to see a provider, to see a doctor. And so the models are changing, the investments are changing. We see what they call physician extenders, or APPs, advanced practice practitioners, which are nurse practitioners and others, to help extend the physician's reach. But it's not only in the educational world, right? It's working with the department on programs that can help fund some of those programs, whether it be Georgia Strong or Georgia Aid, are key programs to that. So, we see it as the biggest threat that we have is certainly our ability to fund healthcare services, but our really sort of right behind that is just having the workforce to do it, and especially if we think about rural healthcare, how do we expand services, right? How do we bring, Sally talked about, how do we bring behavioral health services to all communities that need it? I imagine everyone in this room, behavioral health has affected your families one way or the other, or still are. And it's an area sometimes ignored, not only in the industry, but by government and by insurers. It can be a challenge, but partnerships are vital to our future. We just can't sit in our silo thinking it's somehow somebody's going to take care of it. We better be aggressive, and we better get out in front of it.
That's right. We know less than 4% of the medical students in the United States are from a rural community.
That's right.
And so growing your own and investing in your own is vitally important.
Yeah.
And when you come home.
When you talk to the ones that aren't, and you say, hey, would you ever think about, they look at you like you got 3 eyes. And they say, well, how many coffee shops do you have in town? And we say, well, we got a couple, but they're really good.
Right.
So, and if it's not that student or that prospective worker, it's who's with them, right? Is it their spouse?
Absolutely.
And, are they going to be happy? And it's a whole thing.
It's a whole community.
It's a whole thing,
in.
and it does. It takes a community to make that happen, and we've seen that as we've recruited providers. We've gotten our community involved in that recruitment.
Absolutely. Sally?
Partnerships are now on our end. I would say now we are in 12. We are just finishing the contract on our 13th hospital, where we actually go into the emergency rooms and work with the patients that are there with a primary mental health diagnosis, with the goal of taking that workload off of the ER nurses so we can do the assessment, help get them placed in the appropriate place, and so the nurses there can spend their time working on the patients that are there for a medical condition and not making numerous calls, trying to find an appropriate place for those people. We are trying to take a step further from that now and partner with different persons, our agencies, primary care physicians within the community to have points of entry where we can do those assessments or meet with those patients there and hopefully prevent them from getting to the emergency room, because that's just not the appropriate place for them. So we're hopeful. We've got some of that in the works now, and that's really our plan, and hoping to expand that throughout the rural communities. I told Commissioner Burke, hint, hint, he may see some of that with this Rural Transformation Fund, but those are some of the things that we do, and we partner with our government agencies all the time in trying to figure out what we can do to provide the best care, mental health care, to our citizens in need. Dr. Burke?
Yeah, I think that what you described as far as the collaboration and just as the award earlier for the multi-county folks that are doing a lot of economic development. I mean, Georgia's a big state geographically. It's a very diverse state culturally. The health care issues that Southwest Georgia has, the folks in Northeast Georgia is completely different.
Right.
And so if we all don't communicate with each other and talk about the challenges together and work for mutual solutions, we're toast. And I think Governor Deal, before he left, and now Governor Kemp have really done a very good job of getting stakeholder engagement throughout the state and making step-by-step changes. You know, you can't go from one of the worst healthcare outcome states in the country to the best overnight, because you've got to have infrastructure in place before you can start care delivery. And so you have to develop partnerships. I've seen probably a dozen people in this room today that I'm in communication with. Scott's certainly one of those, and your team, Sally, has always been available to give us feedback on when we have what we think is a good idea in behavioral health. We're going to call these folks and say, would this help you? Or they know to call us, can you help us do this? And you know, that's the key part of, I think, being effective from a government level, is actually making sure you're hearing from people on the front lines of healthcare or whatever area of government you're dealing with, and you get, you know, honest feedback, the good, the bad, and the ugly, and then work together to try to find solutions. And I think that's happening every day in Georgia, and I think we're making great strides. So.
And I respect that in your leadership. You never do things that will impact other people that you don't talk to them about it. There's a lot of humility, but greatness in leadership in that, so we appreciate that. I'm going to start with you then on this next question, because you alluded to it, so I know you're excited about it. So recent federal policy and funding changes in healthcare are going to have short and long-term implications. We know that. So can you share with us how you anticipate that impact to look for access to care and accessibility for rural Georgians, but also then looking at putting on your doctor hat and looking at how that's going to affect physicians in the communities as well?
Well, you know, again, healthcare is a super complex system with so many variables, and when you put your finger on the scale over here, then it affects 15 things, you know, down on the other end. So we try to be very thoughtful, but you know, the care delivery model that I was talking about, the payment model, I think is critical, but that's going to take a long time.
Right.
The healthcare workforce that Scott's team has been leadership on, as far as innovation of driving new people into healthcare delivery that maybe weren't in that direction until they heard about it and had an opportunity to do it at a younger age than they would, not waiting until somebody's 30 and divorced and all of a sudden has to go to the workforce, so becomes a CNA. Right. We're talking about a 16-year-old that can get a rapid process to get a certification and start earning money for their family, and then continue that growth into other more higher paid positions. I mean, all of those things are critical. But as I said before, the needs are many. Even $100 million, $200 million a year. It sounds like a lot of money, but you know, a new hospital, even a tiny one, knocks out $100 million just,
Right.
you know, like that. So, you know, that we're going to have to be very careful about how we spend the money. And as I was saying earlier with some of my other roles, there are going to be people that maybe didn't get everything that they wished for in this opportunity. But I think we're looking at it from the standpoint of what will make the most difference in the near future. But even more important is long-term stability of rural health care delivery, and what do we need to do to sustain that. And you know, we do have handcuffs on this money. There are certain things that CMS won't let you do with it, and one of those is build a hospital. They don't want anybody taking over the big chunks of this money. So, but there are also other things. We can't pay for anything that would disappear when the money runs out. That's something that you know, they're limiting. They don't want fiscal cliffs where all of a sudden, if that money is gone, that service is gone. We haven't done anything for long-term stability if that happens. So everything's got to be looked at from a long-term lens to make sure that there is some financial stability at the end of the 5 years when that money disappears.
Very good. Sally?
Oh, well, just with, you know, we're talking about perhaps some of the looming Medicaid cuts. Some global landscape for behavioral health is, in general, behavioral health is reimbursed at a lower rate than medical health. And yet we have to staff the same healthcare professionals at the same pay rates in order to stay open. So it is a challenge. It is a challenge to remain open. It is a challenge to make sure we have accessibility to those in needs, especially since COVID, when our costs have increased significantly, but our revenue has not matched that. And then if we have further cuts, there's going to be an impact. So we are constantly looking at what different avenues do we have, how creative and crafty can we be to continue to provide great care within the resources that we have.
You know, I think the funding, the federal funding in the transformation bill, or the part of the big, I'm having a hard time calling it beautiful, but the big bill is, it needs to be transformative, right? How do we really do something? $500 million over 5 years, and then plus some can be huge. So how do we have that stick? You know, but, and Kaylee touched on it, the other side of it, the cuts to the subsidies, the potential other cuts to Medicaid dwarf that $100 million for our state, and dwarf the $50 billion, though $50 billion is a lot. The cuts, the other impact on the other side is I think, catastrophic. If 10% of everybody in Tift County that has insurance today goes to self-pay, guess what? They're not going to get the care that they need timely. They're going to wait until it's an emergency. Cancers are going to be, their cancer diagnoses are going to be delayed. They'll come in with stage 3 and stage 4 cancers that are 10 times more expensive to treat. People will not use the emergency rooms well. They'll not have the access to care, and Tift, Southwell, will suffer financially. And when you suffer financially, you start saying, I say running a hospital is just like a house, just like your house. It's money in and money out, and at times you have to make tough decisions. Maybe you don't go on the vacation you thought you were going to go on because you had to replace the roof or the air conditioner. And so we have all those decisions to make. And you know, it's a challenge. I wouldn't do anything different. I love what I do, and it's always been a challenge. This is just the latest one. But somebody had told me, so I didn't come up with this, but Americans want 4 things in healthcare, right? They want the best healthcare in the world. They want it now. They want somebody else to pay for it, and they usually aren't willing to change their behaviors to improve their healthcare. And some of those might be, that might hurt because maybe that's you or it's us or somebody in our family. You know, in Europe, you can't advertise pharmaceuticals on TV. That's against the law. But we do it here. And why do we do it here? I don't know if Dr. Burke, you were practicing, but my daughter's a physician. She tells me all the time about how people come in and say, you know, I saw these ads, and she said they'll have 10, 15, 20 medications because they saw it on TV, and they want to know if they need to be on that medication, right? It makes no sense at all in how we do it. So we've got work to do. I think certainly as a state, I think we've got the right partners. You heard a couple of them up here today. We are determined. We will figure this out. It's not going to be easy, but all hope is not lost. We just need to change it here and there. But you know, Georgians are tough people. We survive, and then we thrive. So no doubt we will do the same. Very good. Well, thank you for what you do every day, and thank you for the insights that you've shared with us today. So please join me in thanking this great group of healthcare leaders.